Hello everyone, my name is Dr. Shehzad Saeedullah and I am a head and neck and anterior skull based surgeon. Welcome to my YouTube channel where we take complex ideas and break them down into simplified forms for all the doctors to understand. So if that is of interest to you, please hit the like and subscribe button and hit the bell icon so that you get all the notifications from the page. So without further delay, let's get into today's video. So today we are going to be discussing the tuning fork interpretations. For that, I always teach my students this simplified diagram of how the sound reaches the cochlea. In tuning fork, we are basically comparing the two pathways, the air conductive pathway and the bone conductive pathway. The air conductive pathway is the one in which sound, it comes from the surroundings, it goes in through the external auditory canal, it strikes the tympanic membrane, starts vibrating all of these ossicles, the medius, incus and stapes, and then the vibrations are carried to cochlea. This is the air conductive pathway. The second pathway is the bone conductive pathway, in which sounds come, they directly strike the bone. We all know that the cochlea is suspended in a bone. The cochlea is surrounded by bone. So the bone starts vibrating and those vibrations are carried to the cochlea. That is the bone conductive pathway. The principle of tuning fork is that we are going to compare the air conductive pathway with the bone conductive pathway. Now let's take Rinne's for example. There are two possible ways in which Rinne's can act. The first one is called Rinne's positive. Rinne's positive means that the air conductive pathway is better than the bone conductive pathway. And the interpretation of Rinne's positive is that it's either going to be normal or it means that the patient is having sensorineural hearing loss. Now let's take the first one. Why in a normal patient the air conductive pathway is going to be better than the bone conductive pathway? This is because of a phenomenon which we call masking. What do we mean by masking? Let's say that there are 100 receptors in cochlea. Most of these receptors are going to be occupied by the sounds which are coming in through the air conductive pathway. So let's say of 100 receptors, almost 80 are taken up by the air conductive pathway. There are only 20 more receptors free by which the sounds coming in through the bone conductive pathway can be appreciated. So this means that the air conductive pathway is basically masking the bone conductive pathway, which means that the majority of the receptors in cochlea are occupied by the sounds coming into the bone through the air conductive pathway, and that is why there are not many receptors left by which the cochlea can appreciate the sounds coming through the bone conductive pathway. So in a normal patient in which the Rinne's is positive, it means that the air conductive pathway is greater than the bone conductive pathway, and that is normal. Now let's take the second scenario. Let's consider that the patient is having cochlear damage. Again, whenever there is cochlear damage, the patient is bound to have sensorineural hearing loss. So let's say the number of receptors rather than 100 have come down to 50, which indicates cochlear damage or sensorineural damage. Again, most of these receptors are going to be occupied by the sounds which are coming in through the air conductive pathway. So let's say 40 of these receptors are occupied by the air conductive pathway. Again, the air conductive pathway is going to mask the other pathway. That is why even in sensorineural deafness, the patient is going to have a positive Rinne's. So the interpretation of a positive Rinne's is it's either normal or sensorineural hearing loss. Now let's take another example. Let's consider that there is a hole in the tympanic membrane, or the ossicles are dislocated. When this happens, this means that the air conductive pathway is now compromised. This pathway is not as efficient anymore. So what is going to happen? In Rinne's negative, the air conductive pathway is now defective, and that is why the bone conductive pathway is going to take over, and the bone conductive pathway is going to be better than the air conductive pathway. Whenever this happens, this indicates that the patient is having defect in the air conductive pathway, because of which the patient is having conductive deafness. Remember, any defect in the air conductive pathway is going to give rise to conductive deafness. So Rennie's has two interpretations. Number one is Rennie's positive, which means that the hearing is either normal or the patient is having sensorineural hearing loss. And the other is Rennie's negative, which means that the patient is having conductive deafness. The third principle that we need to learn for tuning fork is that of Weber's. I always tell my students, Weber's, it loves conductive and it hates sensorineural. So if Weber's is going to the right ear, this means that this ear has right conductive deafness, or the left ear has sensorineural deafness. So these are the three principles that we need to remember. Rennie's positive is either normal or sensorineural hearing loss. Rennie's negative is conductive deafness. And Weber's, it's going to love conductive and it is going to hate sensorineural. So if Weber's is going towards, let's say, the right ear, it means that the right ear has conductive deafness, or the left ear has sensorineural deafness. Proceeding on with the interpretations, there are 5 possible ways in which Rennie's and Weber's can present to you in clinical practice. So let us take the 5 scenarios and dissect them out. Scenario number 1. Let's say I am doing tuning fork in a patient. I strike the tuning fork, I hold it here. Patients say they can hear well in front, but they cannot appreciate much at the back. This means that the Rennie's is positive. I repeat the test on the left ear. Again, patient says they can hear well in front, but they cannot hear well at the back. This means that the Rennie's is positive on that side too. What does Rennie's positive mean? That the hearing is either normal or sensorineural hearing loss. Now I proceed on with the Weber's. I do the Weber's, I place it here, and patient says that the Weber is centralized, or that he can hear it in both ears. When this happens, it means that the hearing in both ears is either normal or the patient is having equal sensorineural hearing loss in both ears. So this is scenario number 1. Rinne is positive, and Weber central, which means either normal hearing or equal sensorineural hearing loss in both ears. Now considering scenario number 2, let's say this patient is having a hole in the tympanic membrane on the right side. Now what is going to happen to Rennie's? I strike the tuning fork. Since the air conductive pathway is not working, patient will say that he cannot hear well when I am holding it in the front. But as I put it at the back, patient says that they can hear it well. This means that the Rennie's is negative in this ear. Since this ear is normal, I do the tuning fork and the patient say that they can hear well in front but not at the back. This means Rennie's is positive. Where should the Weber's go? Remember, Weber's loves conductive deafness. So if I do the Weber's in this patient, he will hear it in the right ear. So this confirms that this patient is having right conductive deafness. So this is scenario number 2. Rinne is negative in one ear, Rinne is positive in the other ear, and Weber's going towards the Rennie's negative side. This means that this patient is having conductive deafness in that ear. Scenario number 3. Let's say you meet a patient who has a hole in both of the tympanic membranes. So what is going to happen to Rennie's? I strike the tuning fork. Since the air conductive pathway is not working, patient will not hear well in front, but they can hear it at the back. This is Rennie's negative. I do the same thing here. Patient will not be able to hear well in front, but they can hear it at the back. This is Rennie's negative. Rennie's negative means that the patient is having conductive deafness. Now I proceed on to the Weber's. I do the Weber's and patients say that they can hear it in both ears, or the Weber is central. What does this mean? This means that the patient is having conductive deafness in both ears but equal conductive deafness. So scenario number 3, Rinne is negative and Weber central. This means that the patient is having equal conductive deafness in both ears. Now scenario number 4. Let's say I am doing the tuning fork. The patient is having hole in both of the tympanic membranes. What will happen to Rennie's on this side? Since the air conductive pathway is not working, when I strike the tuning fork, patient will say they cannot hear well in front, but they can hear it at the back. Rennie's will be negative in this ear. In the same way, patient cannot hear well in front, but they can hear it at the back. This means that the Rennes will be negative in that ear too. I do the Webers and the patients say that they can hear the sound in the right ear. Now what does this mean? This means that the patient is having conductive deafness in both ears, but more conductive deafness in the right ear. Remember, Weber's loves conductive deafness. Since the right ear is offering it more conductive deafness, that is why it is coming towards the right ear. Another point for the students to note is that you will always be interpreting Rennes first. If Rennes is negative, it rules out any sensorineural component. If Rennes is negative, there can be no sensorineural deafness. There can only be conductive deafness. So, Rennes negative, and Weber's coming towards the right side. This means that both ears have conductive deafness, but right has more conductive deafness. Coming towards the fifth scenario, let's say I am doing the tuning fork. I hold it in here on the right side. Patients say they can hear it in the front, but they cannot hear well at the back, which means that the ear conduction is better than bone conduction. This is Rennes positive. I repeat the test on the left side. Patients say they can hear well in front, but not at the back, which means that the ear conduction is better than bone conduction. Again, Rennes positive. Rennes positive means that the hearing is either normal or sensorineural hearing loss. I do the Webers and patients say they can hear the Webers in the right ear. Remember, right ear cannot have conductive deafness because Rennes was positive in the right ear. For conductive deafness, you need a Rennes negative. So in this case, since this ear cannot have any conductive component, this means that the opposite ear has sensorineural deafness. So this is the fifth scenario. Rennes positive, it rules out a conductive deafness. You do the Webers comes towards the right ear. Since this ear cannot have conductive deafness, this means that the other ear has sensorineural deafness. So let's summarize the 5 scenarios. Scenario number 1. Rennes positive, Weber's central. This is either normal hearing or both ears have equal sensorineural hearing loss. Scenario number 2. Rennes negative, Rennes positive, Weber's coming towards the ear with Rennes negative. This is right conductive deafness. Scenario number 3. Rennes negative, and Weber's central. This is equal conductive deafness in both ears. Scenario number 4. Rennes negative, Weber's coming towards the right ear. This is both ears having conductive deafness, but right ear having more conductive deafness. Scenario number 5. Rennes positive, Weber's coming towards the right ear. This means that the left ear has sensorineural hearing loss. There is another scenario number 6, which happens in rare cases. Let's consider that one. Let's say I am doing the tuning fork in this patient. I strike it, I hold it in the front. Patients say they cannot hear well at the front. I put it at the back. Patients say they can hear well at the back. I repeat the test on the left side. I strike the tuning fork. Patients say they can hear well in the front, but they cannot hear well at the back. So, Rennes was negative in the right ear and Rennes was positive in the left ear. I do the Webers now. Where should my Webers go? We have learned from our tuning fork principles that Webers should be coming towards the side with negative Rennes. But in this patient, when I do the Webers rather than going towards the left, the negative side goes towards the positive side. Now there is a mishap. Now this should not happen. The rules of tuning fork are being broken. They are not being followed. Whenever the Webers is going towards the positive side rather than the negative side and the rules of tuning fork are not aligning, always suspect a dead ear. And which ear is dead? The side on which Rennes was negative. This is called a false negative Rennes. Now what has happened? This ear is dead. The cochlea is not working at all. When I strike the tuning fork, since there is no cochlea to appreciate sounds, patients said they could not hear anything when I place it in the front. When I put it at the back, these vibrations travel by the way of skull all the way to the other cochlea. And that is why when I place it on the back, patient said they could hear sounds, but actually they were hearing sounds in the opposite cochlea. That is why Rennie's was negative on this side. Since this ear is normal, I do the tuning fork and Rennie's is positive. I do the Weber's, and since there is only one functioning ear, the right ear is dead, the only functioning ear is left. That is why the Weber's went towards the left side. So this is a false negative Rennie's. Whenever the tuning fork does not obey the normal rules, whenever Weber's is not going towards the Rennie's negative side, but towards the Rennie's positive side, always suspect that one of the ears is dead. And which ear is dead? The side on which Rennie's was negative. So this is how you are going to be interpreting your tuning fork. Number one, you are going to first interpret Rennie's. Number two, after Rennie's, you are going to be interpreting Weber's. If the Rennie's and Weber's are telling you that the patient is having sensorineural deafness, then you are going to do an absolute bone conduction test. And the absolute bone conduction test is going to confirm whether the patient is having a sensorineural deafness. Thank you everyone for watching. If there are any more complex topics that you would want us to cover, please let us know in the comment section. Thank you so much.